Welcome, everyone. My name is Corinne, and I will be your moderator today. I'm excited to welcome Linda Harvey, Founder and Chief Knowledge Officer for the Dental Compliance Institute, as our speaker tonight, as she will be speaking on air quality in dental settings. Before we get started, I would like to take a moment to go over some housekeeping. This webinar is sponsored by Health First, and Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. Linda, welcome, and thank you for being with us today. I'll pass it on over to you.
Thank you very much for that kind introduction, Corinne. I'd like to welcome our viewers this evening as well. And as we get started, I'd also like to thank Health First for their support of this program. When we think about the air that we breathe, the average person takes at least 16 breaths per minute at rest, which means we breathe about 960 breaths per hour, or just over 23,000 breaths per day. So how many times a day do you think about your breathing? Well, if you're like me, it's not until I have a cold or I do some strenuous activity that I get winded. However, we all know breathing is a 24-hour-a-day activity. And now a little virus called SARS-CoV-2 has caused a lot of people to become aware of their ability to breathe. So this session focuses on the quality of air that you breathe in your dental practice. During this session, we have 4 objectives. First, we'll discuss the relationship between air quality and disease transmission. We'll review recent findings on air quality and airborne transmission of COVID-19. We'll identify current trends, recommendations, and regulations. And lastly, we'll examine strategies for air decontamination and improving air quality in your practice. At a high level, the quality of air, both indoors and outdoors, has been regulated and monitored for years. For me personally, when I think about outdoor air, I think about smog control or even pollen reports for those who have allergies. And in the past, when I would think about indoor air or experience indoor air in restaurants, I used to think about the secondhand smoke, where probably nothing more than just a few feet might separate you from the non-smoking and the smoking section. And then many states began to regulate indoor smoking. Now, in more recent years, there's been a greater awareness on other indoor pollutants, such as mold, carbon monoxide, and radon, to name a few. One thing I'd like us to keep in mind as we go through this presentation is that according to the Environmental Protection Agency, in our home or office, it can be 2 to 5 times more polluted than the outdoor air. Now, I have to admit that during my practicing years as a hygienist, I never gave much thought to the quality of air in my practice unless it was too hot or someone burned the popcorn. Yet now that topic is front and center, and in many ways, it's like a blinding flash of the obvious. Air quality specifically matters to us in dentistry, and especially in regards to the airborne transmission of disease. You may recall there are 3 modes of disease transmission: airborne, bloodborne, and contact. Let's think of them as the ABCs. First is airborne transmission, but let's come back to that one in a minute if you don't mind. And rather, let's start with bloodborne disease. Back in the 1970s and 80s, there was a keen awareness and this growing concern about bloodborne transmission of disease with the discovery of HIV and our subsequent learning curve about that virus. So to protect healthcare workers from contracting a bloodborne illness in the workplace, OSHA passed the bloodborne pathogen standard, which became effective in March of 1992. And if you were in dentistry when I was back then, it was the first time ever that we heard the words personal protective equipment, because healthcare workers were now required to wear PPE and, among other requirements, with the bloodborne pathogen standard. So similar to adapting and adjusting to the PPE requirements back then, now we are adapting and adjusting to enhanced aerosol protection as a result of the SARS-CoV-2 pandemic. The third mode of disease transmission is contact transmission. This can occur through direct or indirect contact with a contaminated surface or even a sick individual, such as shaking hands with someone who may be contagious. They may not know it, you may not realize it, and then you touch your face or eyes immediately after shaking hands. Interestingly, I'd like to share with you some studies that have been conducted about the number of times people touch their face every hour. The first study was published by the Journal of the Occupational and Environmental Hygiene. It recorded subjects as they did office-style work for 3 hours in a room by themselves. On the average, they touched their face 15.7 times per hour. That equates to touching one's face about every 3 minutes, which is pretty frequently. Then there was a similar study of students in South Wales. They showed that the students touched their face an average of 23 times per hour, with almost half of those contacts involving between the hand and the nose or eyes and mouth. Now, of course, when we think about our clinical care, we should not be touching our face or anything else when we're gloved up and we're in the middle of a procedure, right? We should be following aseptic technique. However, for us in dentistry, it means maintaining top of mind awareness about properly cleaning and disinfecting our clinical contact surfaces. So let's circle back now to our topic of conversation, airborne transmission of disease. One of the first big discoveries about airborne transmission of disease that I remember learning about didn't even occur in healthcare. It was Legionellosis. It was discovered and named after a mysterious pneumonia outbreak at an American Legion convention in Philadelphia, and this was back in 1976. So more than 2,000 people attended this conference, and sadly, within a week, more than 130 were hospitalized and 24 people died. The conference was held in July of that year, but it wasn't until after Christmas that the bacterium was isolated. However, it still wasn't discovered why or where the outbreak occurred until the following year when an outbreak recurred. So the scientists finally discovered that the bacterium was spread through the cooling systems of large towers and buildings, because that's where the bacterium was thriving, in those cooling towers, if you will. And it was spread via the air conditioning. And then coming into the future here with us now with COVID-19, we know there was an outbreak of COVID-19 in China back in 2020 that was also associated with air conditioning in a restaurant. This outbreak involved 3 different family groups whose tables were in close proximity, and the airflow was consistent with droplet transmission. So out of those 3 families, 10 people developed COVID-19. So we know that while dental settings have appeared to have a low source of disease transmission related to COVID-19, which is a good thing, we still have to ask the question, is your office as safe and healthy as it could be? Because conceivably, COVID and other airborne pathogens can be transmitted through the air by inhaling droplets from an infected person who coughs or sneezes near you, and we have to think about our aerosol generating procedures. And speaking about airborne pathogens, here's just a partial listing of the airborne risk in dental settings. While SARS-CoV-2 is top of mind, we can't forget about other airborne diseases that we have faced, and may I stress that we have faced for years in dentistry. Remember that cold or flu that you caught and you didn't know where you contracted it? Or maybe the year that you all passed the flu among yourselves, every team member ended up contracting the flu. So when you think about questions like that, where did I come down with this cold? How did I catch the flu? Questions like those should cause us to pause and reflect in general about the quality of air in our work environments. So briefly, let's talk about the size of these pathogens, because the smaller the pathogen, the longer it can remain airborne. So we can see from this chart, the very first one is the SARS-CoV-2 virus. This virus is 0.3 microns in size. And when you look at the remaining ones on this chart, influenza, measles, pertussis, tuberculosis, and varicella, you can see how the size of the particles range quite a bit, from tuberculosis, which can be quite large, up to 5 microns, all the way down to the size of varicella and the SARS-CoV-2 virus. You see, bacteria and viruses are measured in microns. This is a little bit harder to grasp because that particle size is so small. So in dentistry, we always think of millimeters, don't we? That's where our mindset is. We think of sulcus step, overjet, overbite, everything's measured in millimeters. So let me share with you an analogy to kind of put microns in perspective in our world. The eye of a needle, just its basic sewing needle, is 1,200 microns in size, whereas this one strand of human hair is 70 microns. And both of those can be hard to see without reading glasses, right? Or maybe your loupes. Let's look more closely, no pun intended here, at measles, just as one airborne disease. Here's some fast facts about measles. Measles is highly contagious and it spreads to others through coughing and sneezing. If you breathe the contaminated air or touch the infected surface and then touch your eyes, nose, or mouth, you can become infected. And we know that infected people spread measles to others from 4 days before the rash appears through 4 days after the rash appears. Just a pretty lengthy time. Measles can live up to 2 hours in an airspace after an infected person leaves the area. So we stop and think about something we've always faced in dentistry, right? And the symptoms happen to be, some of the symptoms at least, similar to COVID, a cough and a runny nose. But I'd like to just take this one more little bit step deeper for you, and let's look further, because we think about measles being a childhood disease, don't we? Back in the 1950s, before there was a vaccine, all children by the time they were age of 15 came down with measles. And at that time, anywhere between 3 and 4 million people were infected every year, with as many as 48,000 people winding up in the hospital. So by the early 60s, there was a vaccine. However, despite that, and the lower cases for many years, it's still possible to have an outbreak. And we saw this in 2018 when there were 372 cases in the United States that consisted of 17 outbreaks in 25 states. You see, there were 372 cases. 97% of those were imported associated, meaning that U.S. residents and foreign visitors were coming back into our country with measles. That's not uncommon. That's how we saw that SARS-CoV-2 spread so rapidly around the world. And you can see also on the slide, there's a breakdown between the number of individuals, the U.S. residents, what percentage was vaccinated, unvaccinated, and their status unknown. But bringing us to 2020, that was 4 years ago. But just think about even as recently as 2020, the measles surveillance pretty much deteriorated in this country in 2020 because of the SARS-CoV-2 pandemic and the effort and attention that needed to be focused on that. And also as a result, globally, measles hit a 23 record high in 2020. So this is something to bear in mind. We may not see measles every year in our community, but there are things that have been going on in the background that can expose some of us depending on where we're practicing and where the outbreaks occur. So transitioning to our next objective, let's review findings on air quality and airborne transmission of COVID. Let's look specifically at 6 research findings related to the airborne transmission of COVID-19. First, we see that the CDC reminds us that particles 5 microns and smaller may not settle for hours or even days, whereas larger particles generally travel less than 6 feet. Hence, that's where we ended up with social distancing during this aspect of maintaining safety during COVID. So that's an important tip and research finding to bear in mind. Next, one of the first in vitro studies showed that SARS-CoV-2 was detectable in aerosols for up to 3 hours. Personally, I think this study probably contributed to our awareness quite a bit about the quality of air in our practices, because I recall reading that study and then trying to advise clients how to manage that. What should they do? And you may recall receiving some of the earlier guidance as well from CDC. And that guidance included leaving our treatment rooms empty for 15 minutes between patients. That is currently not one of the 2020 recommendations, but at that time, as we were beginning to come back into our offices and see patients, that was a challenge. How do we have enough operatories to do that? And how are we going to balance that in our schedule? Well, third, that same study showed that SARS-CoV-2 can live between 4 and 72 hours on hard surfaces. Now, this heightened our awareness about how we clean and disinfect our operatories, as well as what products we should be using because of the possibility of indirect exposure and through clinical contact surfaces. And truly, this awareness extended from the operatory throughout the entire office. I know offices that were cleaning and disinfecting patients' restrooms after each use, along with other high contact areas throughout the office. And then in the spring of 2020, the Environmental Protection Agency launched a new tool called the N list. N is in Nancy. The surface disinfectant products that were on the N list had submitted information to the EPA to demonstrate that they were effective against all virus strains and variants of SARS-CoV-2 when used according to the manufacturer's instructions for use. So that gave us assurances that indeed the products that we were using were going to kill the SARS-CoV-2 virus. Fourth, several studies have confirmed SARS-CoV-2 can be detected in saliva. Since the earlier studies conducted back in 2020, there have been other researchers that have jumped on board, such as MD Anderson and Yale, Rutgers, all have conducted research that yielded the same results. So when treating a patient who is SARS-CoV positive, there is a possibility of risk to clinicians. And we know that there's that 48-hour window of time where the patient may not even realize that they're positive. And these studies show that the SARS-CoV-2 viral load is consistently high in saliva and is relatively higher than in the pharynx during the early stages of COVID. And this is why there was so much emphasis placed early on about using pre-procedural rinses to reduce that viral load for a short period of time. So again, couple that with the fact that someone who may be contagious but not yet have symptoms, or maybe asymptomatic, brings us to realize that we could have a SARS-CoV positive patient or a patient with measles or anything else sitting in our chair, and they may not even know they're positive or that they have something going on. So lastly, this brings us to just be reminded about this research tip and fact is that SARS-CoV-2 is a single-stranded RNA virus. The RNA viruses have a higher viral rate of mutation than other DNA viruses. As a matter of fact, one source I read stated that the RNA viruses are unstable due to a higher mutation rate, and they also have a higher prone mutation rate. And truly, when we think about all the different variants and subvariants that we've seen with SARS-CoV-2, this continues to bear out and will continue to bear out in the future as we work through the changes and mutations with COVID. So when you consider all these findings, they really play a role in what and how kinds of safeguards we should be implementing for optimum safety and well-being in our practices. And we'll be talking about that more in the next couple of objectives. First, let's go back and recap our experience with the SARS-CoV-2 mutations. You know, back in just last year, our experience with Delta, we learned quickly that the Delta variant was much more infectious than the original COVID-19 strain. For every 2 people who contracted the original COVID-19, 5 were expected to contract the Delta variant. And while the symptoms of the Delta variant were much the same as the original COVID-19, we found that the Delta variant grew more rapidly and to much greater levels in the respiratory tract, and that was very concerning. Looking at this chart on the right just gives you just an idea of how the Delta cases exploded during the 3rd quarter of last year. As you can see, the orange bars on the graph represent the Delta variant. And it looks a bit like a wave, doesn't it? From starting to June to the about the 2nd week in September, you can just see how it just sort of waves and sort of takes over. There's more orange bars all the way across this graph. So we can see how it moved pretty quickly through our country. As we know, the story, aka the pandemic, continues with Omicron. Just when some areas of the country seem to have reduced cases of Delta, the Omicron variant popped up late November last year. It was first discovered in South Africa. The Omicron variant S protein is heavily mutated as compared to other major COVID variants. It contains more than 50 mutations, including between 26 and 32 on the spike protein alone. Some mutations that are the same as other COVID variants, in terms of how this variant would behave. It also has a number of new mutations that leave question marks. Researchers found that Omicron replicates 70 times faster in human airways, but infection in the lungs appears less severe. Okay, that's a good thing, right? At the time, we all wondered whether that highly contagious virus like Omicron was going to be more severe and cause more deaths simply because it spread faster and did not appear as bad in the case. And we did see a South African study that came out early on that revealed that Omicron infections in South Africa were associated with lower rates of hospital admissions and lower disease severity compared to the Beta and Delta infections, which was welcome news again for all of us. So what's going on in the US relative to the Omicron cases since that time? This CDC nowcast map from the first week in January of this year illustrates how quickly Omicron outpaced the Delta cases. The Omicron cases are purple, and the orange sliver are the Delta cases. And you may remember just 2 slides ago how prevalent the Delta was just barely a month or two prior to this, right? So this particular graph shows us how quickly the Omicron variant is mutating. This slide illustrates what change we've seen in the beginning of the year, coming into February of 2022 into early June. As you can see, the whole February, March, April, early this year, we began to see the Omicron subvariants. And by the beginning of June, there were 5 subvariants according to this color chart. And it looks like a colorful wave, doesn't it? You can just see how it's changing so quickly in our country here. Here's a map from the end of May to now that really shows us the pictorial representation, gives us a little bit a different visualization of what's happening at the same time. And the purple color, as we could see, the representing the Omicron variant BA 1.1 is gone, essentially. Look at all the subvariants that have since come in such a short period of time, just a matter of a couple of months. So looking again at this pictorial chart, you can see from April to the end of July, just recently, how this whole wave has changed again. And look on the right-hand side of this chart. These are the different variants that you can see. And there's 7 Omicron subvariants that have been identified. And you can see how the colors and the changes on the left-hand side of the screen indicate that it's constantly changing. So when you or coworkers or people that you know contract COVID, we're all learning how varied the symptoms are now based on the different subvariants. When we share this information, it's more to ensure that we're staying current because COVID has ebbed and surged over the past 2 years. So I think continuing to be fluid in our approach to stay healthy and keep our office as healthy as possible is our best route. In this section, we covered a number of key points. And before we transition to the next objective, I'd like to do just a recap because there's some points that I just really want to stress in this program. And first is the fact that airborne transmittable diseases are not a new concern for us in dentistry. They have been with us for decades. Just now that with SARS-CoV-2, we're more concerned and there's more emphasis being placed on aerosol controls and aerosol awareness, as well as the quality of our air. A second key point was that was because of COVID. This whole awareness, SARS-CoV-2, and the significant number of illnesses and deaths and hospitalizations that we first saw when the pandemic started really heightened our awareness to, okay, are there some things we could be doing better in our practices? And there's always opportunity for improvement. So yes, we can be safer in many areas. And third, we're just now focusing on the emphasis of the quality of the air. So in addition to PPE and the other enhanced protocols that you've put into place, the quality of the air that you breathe in your practice makes a tremendous difference to your overall health and safety. So this brings us to our third objective. Let's identify current trends, recommendations, and regulations. And in particular, let's take a closer look at how aerosol generating procedures and guidelines and regulations intersect for us in dentistry. When considering regulatory requirements, OSHA requires employers, and this includes us in dentistry, to conduct a workplace hazard assessment. And please note that this was a requirement prior to the pandemic. But in the past, we primarily focused simply on bloodborne hazards because that was what was required with the bloodborne pathogen standard. And now we're beginning to broaden our hazard assessment and include an aerosol assessment as well. So doctors, office managers, safety coordinators, you must evaluate the risk of respiratory hazards in your office and be sure that you have that documented. And when we think about evaluating those risks, several questions come to mind. First is, how long can the particulates remain in the air? We know that particles 5 microns and smaller may not settle for hours or even days. So understanding the types of diseases that we would face from airborne diseases and airborne transmission, it's important to recognize the impact that could be happening in your dental setting. The second question to think about is, how far can these particulates travel? I recall one study that was published in the Journal of Dental Hygiene back in October of 2005. That stated that aerosols can spread up to 8 feet from the ultrasonic handpiece. So, whoa, what's in the zone of contamination in your operatory? So what's sitting behind the head of the patient? What supplies do you have? Is your keyboard covered, your mouse? What's in your zone of contamination in your operatory? What's on the side cabinets, for example? And it just brings to mind what can become a contaminated clinical contact surface that we may not even realize it. Third, the question is, where does the particulate reach when it's inhaled? How deeply will it be inhaled? And how virulent is it? That's a significant concern. And we thankfully have seen that the Omicron variants have not been as virulent as the earlier strain of COVID or the Delta strain. So that's a good indication. But we still have to watch as future strains develop and keep our eye on how far does the particle travel and how virulent is it. And lastly, we need to ask the question, could it mutate? Is it antimicrobial resistant? When we think about the growing number of multi-drug resistant pathogens, just thinking of vancomycin-resistant enterococci and MRSA, it makes sense to implement multiple layers of protection in your operatories and throughout your practice, because we know that SARS-CoV-2 is going to continue to mutate. So keeping those 4 questions in mind, let's take a look at, or closer look, if you will, at your risk factors. So as you conduct your hazard assessment based on aerosol generating procedures, you'll have good information to review and keep in mind. As you can see from the chart, ultrasonic and sonic scalars are considered the greatest source of aerosol contamination. So hygienists, please lean in for just a moment, if you will. This is important. And even next on the chart is air polishing. The bacterial counts indicate that airborne contamination is nearly equal to that of ultrasonic scalars. The important thing to bear in mind, regardless of how long you've been in the field of dentistry, is that this information is not new for us in dentistry. Dr. John Molinari has spoken and written about these categories since at least the early 2000s. So what's the difference now? Well, we all know that answer is a little pathogen called SARS-CoV-2 and its cousins, or mutations, if you will. So how have you begun to look at your hazard assessment for respiratory hazards in your practice and thinking about the different areas that to add protections and be safer when it comes to your quality of air? Because ultimately, it's not just about protecting ourselves or our patients from COVID. It's about all the other diseases that could be transmitted from the airborne perspective. Yet we know COVID is the driving force at the moment. So when it comes to regulatory standpoints and the regulations, what does OSHA say about aerosols and respiratory protection in dentistry? So this content is a little bit content dense, and so I'd like to just read with you a couple of statements briefly here. And this is very significant because it's mission critical to understand that OSHA states that surgical masks used in dentistry to protect mucous membranes of the mouth and nose from droplet spatter but they do not provide complete protection against inhalation of airborne infectious agents. But they do not provide complete protection against inhalation of airborne infectious agents. Wow. OSHA goes on to say that among increased precautions dental practices may need to implement, potentially for the first time, in order to comply with existing OSHA standards, is an OSHA-compliant respiratory protection program under the respiratory protection standard. So, whoa, what is OSHA saying here? Well, in what I call the BC days, before COVID, we relied on surgical masks, didn't we, for all of our procedures. And we made determinations based on what type of procedure and how long we needed to be wearing a mask for that particular patient. And we did that for decades. So for decades, we relied on our surgical masks to protect us during aerosol-generating procedures. Yet now, in light of COVID, what worked in the past may not be the best practice or the regulatory requirement of the future. We know that the American Standards for Testing of Materials, ASTM, is the organization that tests and rates surgical masks in several key areas, level 1, level 2, level 3. And they're looking at bacterial filtration efficiency and the resistance to penetration by synthetic blood. That's our fluid-resistant capability. So when you think about these different levels in the past, we used to use a level 3 mask for aerosol-generating procedures. However, in today's COVID era, a level 3 mask is simply not sufficient protection. When it comes to protecting yourself from aerosols, an N95 mask or higher is the best protection. Next, we look at OSHA's additional statement here related to the General Duty Clause. In OSHA's General Duty Clause, Section 5, Parent 1A, A1, requires employers to provide their employees with a workplace that's free from recognized hazards likely to cause death or serious physical harm. Okay, so we think here, COVID may not be as serious physical harm as compared to falling off a ladder, for example. But we know that we should have to consider long COVID and the sequelae after some of the different cases that people have experienced. And over the years, there has been a number of deaths related to COVID. When you think about long COVID or chronic COVID, it's defined as symptoms extending beyond 12 weeks from the initial onset. And I know a lot of folks who've had COVID said they had the COVID brain, they were foggy for weeks afterwards, and hopefully those were short-lived, but we do think about that is a hazard causing sometimes physical harm in the way, but not the same as we said from falling off of a ladder, but it's a different kind of health effect, isn't it? So now when we think about OSHA's statements from the previous slides, it draws our attention to the CDC's hierarchy of controls. Even 2 years into this pandemic, this graphic is just as relevant, and we can apply the hierarchy of controls to help us reduce hazards in our respective practices. I'd like you to consider this analogy. This inverted triangle of the safety controls here is to our workplace health and safety, as a dental tooth chart is to providing quality care and patient safety. I recommend keeping a copy of this triangle, this graph handy, because as you continually evaluate your office to improve safety, these serve as a guidepost for addressing different areas of safety, especially now when we're thinking about aerosol-generated procedures and aerosol transmission of disease and the quality of the air that we're breathing. So believe it or not, PPE is at the bottom of the hierarchy as the least efficient, although we recognize the importance and the legal requirement to wear PPE, especially in light of OSHA's statement about surgical masks not providing complete protection against inhalation of airborne infectious agents. In fact, it means we really should be wearing N95 respirators, right, or higher while performing aerosol-generating procedures. But as an aside to that, I'd like to give you a quick update about OSHA's regulatory agenda. You see, OSHA's in the process of making that temporary healthcare emergency temporary standard from last year, making it a permanent standard. The notice of public rulemaking was completed in the end of April, beginning of May this year. OSHA held conferences, listened to testimony from many different groups, associations, healthcare workers, manufacturers. And I share that because as dental professionals, being fluid in today's environment is critical for adaptability, for the future and the future requirements that we may be having, as well as our sanity as well. So moving up the hierarchy of controls, next is administrative controls. These types of controls generally include a combination of various types of strategies or techniques that will reduce exposure to a safer level. Administrative controls take into consideration training, policies and procedures, and work designs that can lessen the threat of a hazard to a worker. In this case, we're talking about the threat of aerosol-transmitted disease. And administrative controls seek to impact the behavior of people rather than actually removing the hazard. And administrative controls are also more than just providing PPE. I have several other examples listed on the slide for you. These include continuing to conduct your COVID screening for everybody that enters the office. This is still a CDC guideline. The interim guidelines for healthcare that CDC published in February of this year are still in effect, and they still talk about screening everybody that comes into the practice. Maybe by now you've adapted your screening questions, you've shrunk them, you've made them electronic. There's any different ways you can conduct the screening. Continuing to limit guests and visitors in your practice. This is another way to have an administrative control in practice. And also leveraging teledentistry. That's an ideal way to minimize risk and leverage administrative controls and technology at the same time. I know one office that is successfully using teledentistry for their myofunctional therapy patients. So there's many different ways and avenues that teledentistry is being used in our profession. So now third and the final hierarchy that we're going to discuss in this program is engineering controls. Engineering controls seek to isolate people from the hazard. So I'd like you to think of engineering controls as a physical change in the workplace. This isolates you from the hazard by containing the hazard in an enclosure or removing contaminated air from the workplace, for example, through filtration and ventilation. And think about for a second, this has been a long-standing health and safety control in healthcare in general, and particularly hospitals, for decades. We've heard about isolation rooms in hospitals for TB positive or COVID positive patients. But visualize this, if you will. Have you ever walked down the hallway in a hospital and passed by a construction area? If you did, what do you remember seeing? Most likely there was some kind of heavy plastic cordoning off the area, right? And it was sealed with duct tape, and there may have been some special mats on the floor to reduce particles of dust from being tracked from the construction area into the main hospital areas. And those precautions serve to isolate the construction hazards, such as dust particles, from patients, employees, and visitors. So short of doing something like that in a dental setting, what can we do? Well, I'm glad you asked the question. That brings us to our fourth objective, where we will examine strategies for air decontamination and improving air quality. 3 specific strategies for improving the quality of air in your practice include ventilation, filtration, and air purification. So based upon the definitions from the American Society of Heating, Refrigeration, and Air Conditioning Engineers, ASHRAE for short, because that's a mouthful, isn't it? As well as the National Air Filtration Association, will define these 3 categories. Ventilation is the process of supplying air to or removing air from a space for the purpose of controlling air contaminant levels. It can control the humidity and the temperature within a space as well. Whereas air filtration is obtaining the level of particulate cleanliness required by any definition of air conditioning, if you will, in the industry. And in this case, with air filtration, naturally air filter devices are used. Third is air purification. This employs the use of proactive and continuous disinfection methods. In other words, air purification is more than drawing air into a device, such as a filtration to capture particles and odors, maybe capture some pathogens, but purification is the process of putting healthy molecules back into our environment that safely disinfect the air. So let's look further at ventilation regarding your heating centralized heating and air conditioning system, or HVAC for short. Now, I know we all like to have products and equipment that work efficiently and effectively, whether it's our dental equipment, everything from your pump, your amalgam separator, your curing lights, all your sterilization equipment, everything must work smoothly so we can have a smooth, efficient, and productive day. Same thing with your HVAC system. I live in Florida, so having a very efficient HVAC system keeps it cool and comfortable here during our hot summer months. HVAC systems are designed to have what's called a minimum efficiency reporting value. Minimum efficiency reporting value. That's called MERV for short. And the MERV rating is derived from a test method, again, from the American Society of Heating, Refrigerating, and Air Conditioning Engineers, is ASHRAE. And so when you think about that, I'd like you to think about these different ventilation strategies. So let's kind of think about what this MERV rating means. So let's look at the chart on the right. When you look at the MERV ratings, they're rated on a scale from 1 to 16. And this is determined from the Environmental Protection Agency. And if you look at the MERV ratings from 4, say, to 8, you can see how the smallest particle they filter are 3.0 size microns. And we said that the coronavirus is 0.3 microns in size, right? And then it's not until you get to a MERV rating of 14 and 16 do you have the capability of filtering out any particles and viruses as small as SARS-CoV-2. So when thinking about this, just take a look. We'll talk more about some strategies with your ventilation system, but it's important because what level MERV rating you have is going to be based on several factors. How old is your building? Has your system been updated? Do you share the building with other tenants? There's many factors that go into determining what your current MERV rating is. I'm thinking of one practice in particular. We found out that their MERV rating was an 8, and this building is I'm going to guess about 50 years old from what I know. And the dental office is the only healthcare person in that whole group. There's some other businesses like insurance companies. So with the MERV rating of 8, they definitely needed to up their game, if you will, as far as improving the air quality in their space. But more than likely, that was not going to be coming through their air filtration, through the ventilation system. So as we talk about our next strategies, you'll see why it's important to have multiple layers of protection. So there are 3 suggested ventilation strategies that the CDC published in their interim guidance. So let's take a look at what those are and see if you're still employing these 3 strategies. First, determine if you can reasonably improve your MERV rating on your HVAC system. So that's a conversation to have with your heating and air conditioning specialist, finding out, again, how old is your unit, what do you have in place, and is it possible to improve it? So thinking about the office that I just referenced that had a MERV rating of 8, more than likely you cannot take that and convert it to a MERV rating of 14 or 16. That requires newer technology, newer equipment. Next, the CDC suggested in their interim guidance that we should ensure our restroom exhaust fans are functional and operating at full capacity when the building is occupied. So leaving the exhaust fan on in all the restrooms throughout the entire day is a good ventilation strategy. And third, turn off any demand-controlled ventilation controls that reduce air supply based on occupancy or temperature during your occupied hours. So be sure you set the fan to the on position if possible. When you think about demand-controlled ventilation, what they're referring to is when you can set your thermostat to go to a higher temperature, say in the summertime, make it higher with less cooling ability at night, and then have it turn off and on over the weekend, for example. Those are times that you would not be moving air through the space and not actually ventilating the office sufficiently enough. So these are 3 different ventilation strategies that we see from the CDC. So if you used them before, I hope that you're still using them. If you've waned from them, consider implementing them again for additional safeguards in your practice. So this brings us to our second area, which is the filtration devices. So strategies when evaluating air filtration devices include the fact that these devices rely on HEPA filters. And we have to first ask that question. Does it have a HEPA filter? And it may or may not, depending on your make, model, and brand that you're reviewing. And just to kind of back up for a second to ensure we're all thinking the same thing about a HEPA filter. HEPA filter stands for the high efficiency particulate air, and that's officially defined by the U.S. Department of Energy. High efficiency particulate air. So we say HEPA for short. A HEPA filter is typically an air filter that's pleated, and it theoretically can remove at least 99.97% of dust, pollen, mold, bacteria, and sometimes the air particle size is down to as small as 0.3 microns. So next, what are the size of the particles trapped by the filter? That's the next feature that you'd want to look at when you're evaluating air filtration devices. Does it have a carbon filter? Can it eliminate odors? That's a feature on a number of different air filtration devices and as well as air purification devices, which is not a bad thing, just that carbon filters only eliminate odors and they can trap particles, some as small as the SARS-CoV-2 virus. They just don't kill anything. Next, we want to look at the frequency of the maintenance and changing of the filters. Anytime we add a new device to our environment, we have to be mindful of what are the protocols for maintaining this according to the manufacturer's instructions for use. So how often should you be changing the filters? That's something that you should be. Can you put that on auto refill shipment with the company that you bought it from? Or do you have to go to the store and purchase it? I remember buying some basic office type air filtration devices for our office. And 6 months later, we were having difficulty finding the filters because of the shortages. So plan in advance and factor in supply chain shortages so that you don't get caught short on some of your key items. And be sure to put it on your maintenance logs when it's time to change these air filtration devices. Keep that in mind with everything that you're doing. Next couple of questions to ask. Is it intended for healthcare use? How does it perform with aerosol generating procedures? Have the kill claims been tested? What research comes with the device? And those are just a few things to bear in mind when you're evaluating an air filtration device. And you can see a couple of brands that I've just selected here just for illustration purposes, the Medify and the Pure brand. We've learned so much since we first implemented air filtration devices. And some of the devices on the market, we know they can be purchased at a large retail or hardware store, and other devices have to be purchased from the manufacturer or an authorized distributor. But one of the brands here, Medify, is one company that does have several models. This particular model has a 3-stage filter, including a carbon filter. The product information states that it's going to catch 99.9% of particles, very small to the coronavirus size. And of course, the activated charcoal filter helps eliminate odors. The other one, the Pure model, states that HEPA filter captures 99.97% of dust, pollen, dander, smoke, household odors, pardon me. But this product states that it can destroy germs because it has a UVC light. So the reason I share these with you is not to say one's better than another one, but it's so that you can see there's a vast different features. So it's important to ask good questions when you're reviewing these devices. Very important because we've learned so much in the past 2 years. And technology is changing so quickly as well. So third, let's actually consider what we can do with continuous air decontamination, or CAD. This is not a new phrase. It's used throughout healthcare in many different areas and hospitals and other areas. So it's not a new strategy or a new philosophy or new research at all. So in looking at any devices that have this continuous air decontamination, we're looking for devices that continuously generate and release molecules, healthy molecules that seek out the harmful pathogens. And in most cases, they're using molecules that are already breathing oxygen and humidity from the air. So that's nothing new. These devices always include a HEPA filter, and some of them are Class 2 medical devices. And I'd like to bring that to your attention because when I shared my particular situation where we just went to the retailer and bought something simple for our small office space, we didn't purchase a Class 2 medical device. So when you have aerosol generating procedures in your office, would a Class 2 medical device be a good option to review and determine the fit for your needs? And then lastly, be sure that the research illustrates the efficacy, because that's so important. It's just really, we want to be sure that we're looking very thoroughly and not just looking at price and how many square feet does this device cover. So very, very important. So as we begin to wrap up the program, let's do some comparison. Let's compare and contrast the features on different devices and models so you can ask good questions and make informed decisions. So look at the different technologies that you're evaluating. Is there available research? Are you actually looking at an air purification device, or is it more of an air filtration device? Next, ask, does it have continuous or intermittent activity? So is it going to be continuously cleaning your air, or is it only going to be doing it in cycles or short shifts? So just to share with you how an air purification device could fit well with your air heating and air conditioning system, I'm thinking about one study that I read, which talked about the fact that even though you may have a higher exchange of air in your office, and in particular your operatory, that's happening after the fact. And you really need something continuously purifying the air while you're in the middle of patient care and that aerosol generating procedure is going on, in fact. So that's a consideration with air purification devices and how they can be another layer of protection. Next, always ask, what's the square feet that it's going to cover? I'm thinking about offices that we know that have those open bays, and with our pediatric and our orthodontic colleagues, where would we place this device? How many square feet is it going to cover? Having one that's not big enough to cover the area is very important. And you may recall from reading early on in the CDC interim guidelines that the CDC recommends placing your air purification devices towards the foot of the patient in an operatory. So you're drawing those contaminants away from you both and not over your head from one direction to the other, from the side of the room, for example, or out to the hallway behind you. So that's something to bear in mind, because when you look at the placement, not many dental practices have an outlet in that area. So we have to be creative and how to safely connect a device in the right place. One hint that we've shared with practices is to talk to your dental technicians, because there is an outlet usually in the junction box under the foot of the chair. Could that be a possibility to allow you to position your device more optimally? Next, finding out, is this device an FDA medical cleared device or not? And then what pathogens is it going to kill and what particle size? So if we can capture that 0.3 microns, that's exactly what we want to do when we think about particle size. And last but not least, I mentioned the maintenance requirements, but that's so important because I know we have many different devices in our dental practice, and technology is leveraging how we can provide better quality care. And it's just a matter of other items that we need to be sure that we can seamlessly track and be sure that we're keeping everything maintained properly according to the manufacturer's instructions for use. So as we recap, just what is the quality of the air that you're breathing? Take time to conduct that respiratory assessment and determine where you can shore up and improve the quality of air in your work areas. So in order to do that, we reviewed the basics of air quality relative to reducing risk from airborne disease transmission. So this benefits you and your patients alike. We recognize that outbreaks will continue to occur in the future. So preparation is key. We talked about maintaining the standard of care by implementing safeguards, following the guidelines, standards, and the laws. I don't think I mentioned this earlier, but never was it clearer to me during this pandemic than ever before during my career as a consultant and speaker that OSHA uses the CDC guidelines, and OSHA will enforce the CDC guidelines. As a matter of fact, in the compliance directives, which are the set of inspection instructions, if you will, that OSHA gives their auditors, they quote the CDC guidelines. They're looking for signs and techniques and ways that you have implemented transmission-based precautions and standard precautions. So while guidelines might seem like they're nice to know, they are very important for maintaining a safe practice. And in many, many states, the CDC guidelines are written into the Dental Practice Act, and therefore they're already law in those many states. Fourth, we talked about implementing proven technology to enhance your quality of air. So it has been a pleasure presenting this program. I'm looking forward to the opportunities that you have to move forward with some of the strategies and ideas we talked this evening and make sure that you have the safest air possible when breathing in your practice. And I thank you for attending this evening.
Thank you, Linda, for your time and expertise today. And thank you again to Health First for sponsoring this webinar. We did record tonight's webinar and we'll email the recording out sometime in the next week. We would appreciate your feedback via our survey that will pop up on your screen shortly. Thank you all for joining us, and we look forward to seeing you on future webinars. Thanks again, Linda.